not the best at this, so let me know if this is working. Can you see it?
Yes.
Yes.
Oh, great. Okay, so, you know, interventional radiology, it used to sort of be considered a field really where our clients were other doctors, and patients didn't really know so much about what we do. That is to say, you know, patients were referred to us by other clinicians and we sent patients back to them. But that's changed a lot. And really, we have a pretty significant role in the care of patients right from the time, you know, from cancer patients, right from the time they're diagnosed. In fact, oftentimes we make the diagnosis through their treatment. And ultimately, a lot of the work that I do is palliative. So these are just some examples. So, you know, if a patient comes in with a lung mass, I know somebody mentioned, you know, their brother having to undergo lung cancer surgery. A lot of times patients come in with a mass, and it's interventional radiology oftentimes who actually does the biopsy, which helps people or transitions people from being, you know, people to patients. We do a lot of ancillary things, and those of you who are in the chemo units are probably pretty familiar with patients who have what we call venous access devices, or catheters or tubes that allow us to administer the chemotherapy without IV lines. Do they use a lot of metaports there, or implantable ports for chemo? Yeah. Well, we're the people who actually put those in. We also have, you know, sometimes a role in treating and sometimes curing patients of cancer with things like ablation, which we'll talk about, and embolization. And as I mentioned, you know, unfortunately, you know, a lot of patients don't respond as we'd like to, or present with pretty advanced disease, and we're really doing procedures for those patients to try to palliate their symptoms and make them comfortable as maybe they transition to hospice or end-of-life care. So, you know, this is essentially just written down. You know, interventional radiology is probably very similar in terms of practice to what you've experienced with radiation therapy in the radiation oncology, for those of you who work with them. You know, we're a procedure-oriented specialty, but we see patients in clinic before we do procedures. We evaluate them. You know, in many ways, we have longitudinal care of these patients. So I talked a little bit about, you know, metaports. These are things that you would see for patients who have chemotherapy. This is what a metaport looks like on an X-ray, or I don't know if you call them metaports or implantable venous access devices or whatever, where you have a little well that sits under the skin on the front of a patient's chest that's attached to this catheter that really goes all the way down into the heart here. This is the heart, obviously. Another one on the left side. This one's a little easier to see. And these are really terrific devices because, you know, they're completely implantable, meaning when a patient's not getting chemotherapy, it's completely subcutaneous devices. But when they come to the chemotherapy center, the infusion center, we can put in that specialized needle into that little well and have access. So when they're infusing the chemotherapy, they're actually infusing it, you know, all the way down here, sort of straight into the heart. I love this picture because this is the company's picture on their website, and there's no patient who has one of these devices that's looks quite this healthy and good. But another thing we do, as I mentioned, is palliative. So for patients, this is a CAT scan. I don't know how, are you guys pretty familiar at looking at images, or should I walk through them a little bit?
Walk through.
Walk through, okay. So, you know, CAT scans, essentially, you know, we acquire, it's almost like if you think of the body as a loaf of bread, and then, you know, you sort of slice and then take out a slice and look at it from the bottom up. So it makes the right side of the screen the left side of the body, and the left side the right. So it's really just sort of like you're looking at a slice here, and this is a slice through the chest. And just like on X-ray, bone is white, right? So this here is your sternum or your breastbone, and then you can see the ribs, around the side of the chest here. Black is air, just like on an x-ray. So this is the left lung. This is the heart here. This is the aorta. This is the spine, right here in the back. And, we sort of like to joke that, God made two sides symmetrical so that we could compare one side to the other, right? So if you look at this left lung, which is full of air, black here, this right lung is not so full of air. Here's the air here, but you notice that there's a lot of fluid essentially in the right chest around the lung, kind of squishing and compressing the lung. So this is, and I'm sure several of your patients have had this, and your brother who had lung surgery, may have had something called a pleural effusion, which is that fluid that accumulates around the lung. And the way historically we've treated this is to put in chest tubes, which are like giant hoses that go, through the skin into the chest to allow that fluid to drain out. This is a relatively newer device called a Pleurex catheter, which same thing, it's a catheter that's sort of implanted and patients can go home with it and they can drain themselves into this little bottle, but none of them look quite that good. Some patients, develop a lot of this fluid in their abdomen. I don't know if you've seen patients, especially with liver cancer or sometimes with pancreas cancer, who, they can be quite emaciated, but their bellies are, full and tense with fluid. Likewise, we treat these people sometimes by putting this catheter in, which sits in the belly, and then this part is outside of the belly and can drain that fluid. Or sometimes we put in something similar to the Metaport, which is a completely implantable system that can drain the ascites or fluid that collects in the abdomen through this little chamber that's completely implanted under the skin. And it sort of gets that fluid back into the venous system, just like, this is almost very similar to a Metaport, right? And this is really tremendously advantageous, for patients who have these problems. Likewise, sometimes cancers, especially cervical cancers, sometimes colon cancers, kidney cancers for sure, can block the kidney and prevent the kidney from draining normally, in which case, we're the people who put these tubes in, generally through the back into the kidney. This is a kidney here. And here's this tube going into the kidney. Here's another example of it, the tube going into the kidney and into the bladder to allow, urine to drain, because if kidneys stay blocked for too long, ultimately kidneys can fail. Likewise, in the bile ducts, for people who have blockages of the bile ducts in the liver, we can put these drains in. Sometimes we can put these stents in. But what I really wanted to talk about is, and I know some of you work in radiation therapy and seeing these patients who are undergoing treatment for their cancers, is we have a role in treating cancers too. Meaning if patients, this is just a schematic of a liver here. So this is the right side of the liver, the left side, the gallbladder is sort of tucked in here. The liver is a really common site of metastatic disease. So for your patients who have colon cancer or sometimes lung cancer, a lot of other cancers wind up depositing in the liver. And in some of those patients, it's the liver metastases that wind up ultimately causing their demise. So I actually should have shown a liver here, but one of the things that we can do, which is very similar to radiation therapy, is something called ablation. And essentially that is, we can, through the skin, so you can see here, these little applicators, we literally put these needles directly through the skin into a tumor that you see here. I don't know why it's coming up as Google, whoops. We can put needles directly through the skin into the tumor and apply either extremes of heat, like radio frequency current or microwave current that will literally heat up and kill tumor cells, or sometimes we can decide to freeze tumor cells by doing what we call cryoablation. So freezing, tumors like in this case, and actually you can see this is cryoablation where we froze it, and you can actually see this is actually an ice ball that forms in the tumor, and by tumor cells, like any cells in the body, are susceptible to extremes of heat or cooling. We can kill cells that way. And I think I have an example in the liver. So this is what we call a PET scan, which is it's very much like a CAT scan, although we inject patients with something called FDG, which is like a sugar analog that's radioactive, so we can see, hypermetabolic lesions, so areas that sort of take up sugar, more than they should. So you can see, I think I lost my mouse. So you see this sort of spot in the liver that corresponds to a liver metastasis in this patient with breast cancer. So what we can do is we put this needle, a special needle, sort of through the skin into the tumor, and essentially we turn on a generator and cook that tumor, and ultimately we sort of blast a hole where the tumor used to be. So that's actually very similar to what your patients go through in radiation therapy, although it also has differences, right? Because this is actually done as a one and done outpatient procedure, meaning patients go home the same day. On the other hand, it's a little bit more invasive, right? Because when patients go to radiation therapy, for the most part, they get simulated, and it's an external beam of radiation that goes in and tries to do the same targeting. Now, generally, when we might choose this is for patients who have very small tumors, or very small tumors that are also small in number. So you can imagine we can't go poking holes, indiscriminately through the liver. But it is an alternative for some patients, and in some patients it's very effective. Another thing we do is embolization. I don't know, do you know if any of your patients that you've taken care of have had what's called an embolization?
I'm not aware.
No? Okay. So these are primarily for patients with primary liver cancers, so something called hepatocellular cancer or neuroendocrine tumor, but also patients with colon cancer or breast cancer may benefit from this type of therapy. And the liver is sort of a funny organ. I do most of my work in the liver, so that's why I'm focused on it. But the liver, when you go to school, right, you learn that an artery goes to something and a vein goes away, right? The vein takes the deoxygenated blood away from the organ. But the liver is a little funny. It's most of the normal liver gets its blood supply from the vein that drains your intestines, and only a very small fraction of the blood that supplies the nutrients to the liver actually comes from the artery. But the tumors, as I've tried to sort of show, graphically here, so if this is a tumor, this is a tumor, this is a tumor, they get almost all of their supply from the artery. So when we can direct the therapy directly to the artery to treat tumors without killing or damaging the surrounding liver. And this is most of what I do, which when you stop to talk about it, you really sort of remember how cool it is. On a day-to-day, you sort of forget sometimes. Have you heard of Y90 or yttrium 90 or sometimes radioembolization? We can do all sorts of things to the arteries. We can go and block the blood supply to starve the tumors. We can actually directly inject radiation, just like, we talked about external beam radiation. Essentially, the patient will lie there and we'll direct a beam, through the skin into their tumors to try to kill the tumor. We can actually inject little beads with radioactivity directly into the arteries to cause just a very localized high dose of radiation, which is, pretty cool. And this is what it looks like. So this is This is actually an MRI, which looks kind of similar to the CAT scan in that it's a slice through the body. This is the liver here. And we can see actually that this liver is kind of lumpy bumpy. You know, the liver should have a nice smooth capsule. And that lumpy bumpy sort of appearance is what we see when patients have cirrhosis, right? Because cirrhosis essentially from hepatitis or alcohol, you know, is essentially a scarring of the liver. So it sort of retracts and you wind up seeing, you know, this sort of appearance. This is the aorta here. This is the spleen. The spine looks black in this one because it's an MRI. So this here is the liver. And within the liver, we see these two spots, right? This spot and that spot. And the reason we see it like this is the aorta again, is because they're really hypervascular, meaning these types of tumors really sort of suck in a lot of blood flow from the artery, right? Which is why we can treat the artery and treat the tumors. And this is what it looks like. I think this is super cool. I feel like I play a video game all day long. So what I'll do is through the groin, through the artery that supplies the leg, is I'll just put in this tiny little catheter. And you can see this catheter here, this sort of line up here. And we have all different shapes that we can use to sort of select the arteries that we want. So this is actually the artery supplying the liver here. And this is the artery that supplies the intestines and the pancreas, sort of live in here. And what I can do is when I inject contrast with this X-ray dye, see it looks black in this picture, the contrast that we've injected. If I wait a minute, I can see, you know, those two tumors that I saw on the MRI before, you know, light up. And then I can go figure out which exactly blood vessel supplies those tumors. And once I figure that out, I can actually go and block them. So if you see here, you can see like this artery here, see that supplying this tumor, and this one up here supplying that tumor. But what I do is go in and apply a treatment directly, to the artery, and so you don't see those tumors anymore, and you don't see those vessels because I went in and kind of zapped them, and we can see, you know, a really nice treatment effect immediately afterwards. And, you know, the patient only gets a Band-Aid on the groin when we're done, which I think makes this incredibly cool.
And can you just tell us how do you cut off the supply? Like, what do you actually do to that artery to cut off the?
Yeah, so there's a lot of different things we can do. Usually, and every different center has their different way of doing this. What we do is we inject these tiny beads, and they're really about 40 microns in size, which is about the same diameter as a human hair, although my hair is a little thicker than that, so maybe mine is, you know, 100 microns. But, you know, sort of you know, they're really tiny, and you can't even, they come in a solution, so your eye can't even really resolve the individual beads. They're so small, so it just looks like a little cloudy solution. But essentially, once we get into that teeny tiny artery, you know, like this one that we wanted to block, and the catheters we use are about 1 millimeter in diameter. So the catheters that I'm using are, you know, like a piece of angel hair spaghetti, but we inject those particles just like a liquid through the catheter, and essentially, you know, and we're watching with a fluoroscope, which is like real-time X-ray. And once we've injected enough, we can see that there's just stasis, or that the blood flow in that artery is static, which means, you know, it's done. Yeah, cool. But you can do all sorts of other things, meaning I can inject radiation, you know, beads that are laced with radiation, which are beta emitters. So they, you know, emit really high doses of radiation, but that only span a centimeter, you know, or we can actually inject chemotherapy into the arteries.
I have a quick question too.
Please.
Nancy, when you were talking about ablations and embolization, that sounded fascinating to me, and I'm wondering how safe is that? Of course, quite a bit safer than chemo, I assume, but are there a lot of side effects with that? Or is it more of is that what targeted therapy is, or Is that a
Good
difference?
question. So targeted therapy, I mean, it actually, we should have taken the name targeted therapy first because that sounds really good. But this is what we call local regional therapy or regional therapy because we're really targeting sort of one organ in treatment. Targeted therapy generally refers to when we do a biopsy, as I mentioned earlier. Essentially, we're putting a needle into a tumor and we're taking out a little worm of tumor cells that we send to the lab. And the lab then will say, is this cancer, isn't it? If it is cancer, they'll try to do special stains to figure out where the cancer came from, because it makes a huge difference whether, the cancer started in the colon or the lung or the liver. And that's pretty much where we were in 2000. Now in 2020, since they've sequenced, the genome, we can do what we call targeted therapy. And what that means is that in addition to looking at that little piece of tumor to see, is it cancer or isn't it, or where might it have come from, they can actually look for a huge slew of genetic mutations, not genetic mutations like you think of, in a person, but really specific to the tumor cells. Because tumors, one of the characteristics of tumors is that they have mutations that allow them to, grow in an uncontrolled way. And when we do that biopsy and we run it through what we call a next generation sequencer and we see all the mutations that the tumor has, sometimes some of those mutations are what we call actionable mutations, meaning sometimes we don't know what they mean or what they do. Sometimes we know that there's a mutation, but we don't have a drug that can sort of target that area. But sometimes we find a mutation Sorry about that.
We're back.
Sharon, get back on? What happened?
It said the host lost connection, then which is Sharon, so I'm not sure.
Yeah, I don't see her.
I don't either.
All right, well, I'll go on because now I'm excited. But
Okay,
right.
it's Monica.
Those are,
Um, Sharon lost power because of the storm that went through her Wilseyville.
oh,
So
Hello, can you hear
calling
now?
me while I was on the phone, and so we now have it signed up, and you're ready to go. And she's
Okay,
going to
all right.
try and call in on her phone.
so you know what a targeted treatment is a drug that we have that can really target a mutation that's specific to somebody's cancer. So for example, if you've dealt with patients who have colon cancer, you might have heard of a KRAS mutation, which is a specific genetic abnormality, you know, commonly seen in tumors, that we have a drug that can actually, you know, target that mutation. So that's what targeted therapy is. So it's a little different than, you know, what I do, which is called local regional therapy. But honestly, I wish we had gotten targeted first because it sounds much better.
thank you. That was great.
Let's see if I can get back to sharing the screen. Does that
Yep.
work?
Yeah.
Okay, great. And this is just another example of what it looks like in a patient who has neuroendocrine tumor. And this is a liver, again, pretty lumpy, bumpy liver, and it's hard to see, but they're really just innumerable tumors in this liver. So when we go into the artery, just like we did last time, we put this little catheter up into the artery. And when we inject contrast, we can see, you know, these hypervascular tumors in the liver. And after we block them, this is a month later, we can see that on that side of the liver, you know, now we've got these black things are really just holes where tumor used to be. These tumors get most of their supply from the artery. So when we block the artery, you know, essentially the tumor cells starve. They don't get oxygen or nutrients and they die. And they almost make the liver look like Swiss cheese, you know, here. And you can see these are the live tumors on the other side that hadn't yet been treated. So you can really see immediately the effect of, you know, doing these types of procedures.
Mhm.
Finally, you know, as I mentioned before, with drainage of the pleural effusions, you know, a lot of these patients, unfortunately, at the end of their lives, you know, have intractable pain, sometimes because of bone fractures, you know, due to cancers, sometimes because, in particular, pancreas cancer, because it sits right on the nerves that can cause, you know, innervate the celiac plexus, and they cause, you know, horrible back pain, if any of you have seen that.
Yeah.
So some of the things we do are what we call neurolysis. So nerve cells, lysis, you know, killing cells, where we can put these needles directly through, these are the kidneys here. So this patient's laying on their belly because we can see the spine is back here and the ribs. This is the liver over here and the kidneys. And we know that when a patient has pancreas cancer, that these nerves that live right in front of the aorta are, you know, sort of invaded by the tumor, and it can cause really intractable pain. So what we can do is we can put these needles into that area and literally inject, we use alcohol, so very high concentration of denatured alcohol just into that area to kill, you know, or deaden those nerve cells, which really can make a huge difference in patients' lives. This is another person laying on their belly. Apparently, we make patients lay on their bellies a lot. But you can see that this is the hip joint. So this is the femur, and this is the acetabulum. So the part of the iliac bone where the you know, femur sits here. And here you can see relatively normal looking bone with this sort of dense white cortex and the trabecula, you know, the normal sort of structure of bone inside. On this side, though, you see how the cortex is broken. So here's the cortex, you're missing a piece here. Here's the cortex, you're missing a piece here. And in the middle of this bone is a metastasis. So cancer is sort of in that bone and eroding through the cortex here. And these people have horrible pain you know, all the time when they rest, when they move. You can imagine those little bone, you know, fragments moving,
Yeah.
and, you know, you're constantly living with a fracture. So what we can do in these cases sometimes is I didn't show the needle, but we can put a needle through the skin into this area and darn it, and inject what we call methyl methacrylate, which is a type of cement, to sort of do two things. One, it can kill tumor a little bit because it heats it up, but that's not really the primary reason, but it's really just to stabilize that bone. It's almost like putting a cast inside of the bone to, you know, prevent those little shards from moving around and causing people, geez, I don't know what's happening here. Ah, there we are. To really, you know, make people more comfortable at the end of their lives. So, oh, I put up this isn't my partner's number. But these are the kind of things that we do. And probably, if you're like most people, you haven't really heard of interventional radiology, but being that you, you know, volunteer in a cancer practice and have been dealing with these patients, my guess is that many of the patients who you've helped, you know, take care of and help navigate their cancer story have seen us in interventional radiology. So I just wanted to give you a little bit of a sort of introduction into that and what we do. And if you guys have questions or anything, I'm happy to answer them as best I can.
And I wanted to ask a question. Have you seen shifts or changes in specific cancers? What has emerged as the dominating cancer? What perhaps is not appearing as much as it might have in the last decade? I really don't know what you're seeing.
So there definitely are trends. Most cancers, fortunately, are declining to some degree. Some cancers are increasing for real, like pancreas cancer, we're seeing more of. Primary liver cancer, so those cancers associated with cirrhosis and hepatitis, we're seeing more of. Some cancers we see more of because we catch them earlier with screening. So I don't know exactly what the numbers are now for breast cancer because I don't deal with breast cancer a lot, but you know, there has been a significant increase in the number of cancers that we catch by virtue of the fact that we're looking for them a lot more closely than we have in the past. Some cancers, we've done a darn good job at not eradicating, but are going down significantly, like cervical cancer, because we know the risk factors and risky behaviors. And also now, you know, all of our kids are getting vaccinated against HPV. So it's really pretty uncommon to see, I mean, I shouldn't say it's uncommon. It's less common now to see cervical cancer than in the past. Colon cancer, I think, is relatively stable, although it might be rising a little bit. I'd have to go to the, you know, there's a terrific website. The American Cancer Society website has terrific graphs and charts and, you know, can answer things in a more objective way. You know, obviously I work at a cancer center, so, you know, my experience here might be different than is the general population, but those are sort of the trends that we see in general.
Thank you. Thank you very much.
And I'm a lung cancer survivor, and I'm interested. I know I'm hearing that there's been quite a few advances in that. Can you talk about that a little bit, or is that the way you're feeling? Or
Yeah, I mean, you know, lung cancer, again, I'm not a medical oncologist. I do interventional oncology, but lung cancer was really the prototype for targeted therapy. So, you know, back in like 2004, when we found the EGFR mutation, right? It was a specific mutation seen more in women than men, more in non-smokers, more in younger people. And, those patients responded really well to the first kind of targeted therapy. So those erlotinib and gemfitinib and those types of drugs. But, lung cancer especially has really changed, even in the time that I've been practicing, meaning when I started practice, when you did do you mind if I ask what year you had it, or?
2015.
Oh, yeah. So fortunately, you've already benefited from some of the advances. But, in 2000, you had what we call non-small cell lung cancer, or you had small cell lung cancer. And that was it. Now, non-small cell lung cancer has really been subdivided in a lot of ways where we understand and can guide treatment a lot better than before. And, as I mentioned, lung cancer is the absolute prototype for targeted therapy, meaning there are mutations specific. Actually, a guy I work with named Mark Chris, discovered some of these specific mutations in the tumor that we have drugs to hit. And it's really changed the landscape completely. The scary thing about lung cancer is, while I think overall the incidence is going down as people learn about, smoking and risk factors and things, we're seeing a lot more lung cancer in younger women who are non-smokers. My mother, actually, she died 22 years ago and was a non-smoking woman with, lung cancer. It's really, it's scary, right?
Yeah. Sure is. But that's kind of encouraging, though. I appreciate it. Thank you.
Sure.
Yeah, so when did you decide to go into interventional radiology?
So, I feel like I'm super lucky to be here and doing what I do. But sometimes when you look back and you realize how you made decisions, you go, really? Like, is that really how it works? So actually, I was an animal science major at Cornell. So I wanted to be a vet. And I took livestock nutrition as part of my required courses. I kind of went, no, this is not for me. and I was like, well, I really like medicine, but I definitely don't like livestock nutrition, and I kind of said, well, it seems like medical school would be a good idea. So I went to medical school, and I really liked radiology. I think radiology, I'm fairly tech oriented, so I like that. I like the sort of episodic nature of care. I'm personally not somebody who would be great at, managing somebody's diabetes for 30 or 40 years. I think it's great that people do. It's just not me. So radiology seemed a natural sort of fit. I actually thought and intended to go into pediatric radiology because I thought that was really cool. And in pediatric radiology, they really cover the whole body, similar to interventional. But, some areas of radiology, it's like neuro, you really only do, a small area or things like that. So, but on my pediatric radiology rotations, I'd get to 3 o'clock in the afternoon and I'd be like, oh my God, is this day not over? How is it possible this day is not over? So I was like, oh, that seems bad. Because unless I want my life to take a really long time, pediatric radiology, would not be great. But when I went into interventional, because we have to do rotations in every area, you'd start at, 5 or 6 in the morning and, to be 8 or 9 o'clock at night and you'd kind of look at your watch and go, oh my God, I didn't even have lunch, but you were having so much fun. It just, that the days sort of flew by.
You found your niche then.
So I found my niche. Yeah.
Great.
And it's been great. I mean, I have a terrific career. I love my job. I love my patients. I'm sort of sad for the way that medicine is practiced in this country in general. I think it's frustrating, as a provider now, I spend so much of the time on the computer and it's horrible. It's horrible for everybody. I hate it. I don't spend I mean, I get to spend a lot of time with patients because I'm doing procedures, but when I see them in clinic, you know, and you're face to face, it's really, I'm face to face with the computer and the patient's, you know, face to face my side, which is terrible.
Mhm.
But in general, I do love what I do.
Yeah. How is Sloan Kettering handling the COVID? Are they pretty much full speed or not so much now with the being right in the city and so on?
Yeah, you know, we're pretty much full speed ahead. You know, not a lot of patients are interested in delaying cancer care.
Yeah.
I think our new visits are down, you know, because in general, we catch patients from all over the country and people aren't traveling,
Yeah.
you know, now for their care. We've really ramped up our telemedicine, you know, visits a lot.
Yeah.
There's only so much I can do with telemedicine. You know, I can do follow-ups and, you know, educate people, but I can't do procedures, you know, by telemedicine. So, yeah, so that's you know, it's very different for different specialties. You know, the medicine, you know, oncology, they can do a lot of, you know, what they need to do, you know, by telemedicine, although you miss a lot in not seeing patients face to face. You know, and some of it's really important. So sometimes, you know, I'll see a patient by telemedicine for a procedure and, you know, they're sitting in front of me like you are now, and, you know, you kind of assess as best you can. Obviously, you can't do a physical exam. You ask them how far they walk, and you figure you have a sense, and then they come to the hospital and they go, oh my God, you can't tolerate a procedure, let alone a haircut, you know? It's hard.
Yeah. Yeah.
Yeah.
It's interesting when you mentioned the telemedicine visits. I have had a couple of telemedicine visits, and we have ended up in great political discussions.
Oh boy.
And I
Oh, dear.
wonder whether that would have happened if we were in person. I have no idea. But the world has changed, but people are lucky to have you in their lives to help them, save them, treat them with the passion that you have. So that's very inspiring. Thank you.
Thank you. I mean, I think what you guys do is really important. You know, it's a big part of the patient experience. And I think, you know, I do always feel badly that I can't always spend as much time with people as you'd like to. And in some ways, hopefully you guys fill in those gaps a little bit and can, you know, be with people because, you know, with all this technology we have and all the, I don't know, everything, it's really important to be with people.
We're missing the face-to-face too, you know, of course it can't be helped, but that's hard.
But I'm sure people are very grateful to know you're out there and, you know, getting
Yeah.
phone call. It's very important. You know, it was so sad, you know, for these months. I mean, for 6 months, you know, when patients got dropped off for procedures, they got dropped off at the front door and their care partners weren't allowed in.
Yeah.
Gosh,
You know, it's just,
terrible.
it's
Yeah.
awful. It's terrible. I mean, it's bad enough to have to deal with cancer, but to have to deal with cancer and feel
Yeah.
alone, and for their care partners to be then circling, you know, the blocks outside, not allowed in. Ugh, it's been terrible.
Yeah.
Are they allowing them back in now?
Look who's there. So,
Hey, there she-
so we are to some degree. So now you're allowed to have one care partner come with you pre-procedure if they filled out, you know, the COVID form. But I don't think we're allowing people in the recovery rooms, and we are allowing visitations. You know, but it's staggered by floor. So where it used to be that visiting hours were like 8 to 8. You know, come anytime you want, stay as long as you want. Now each floor, you know, has a pretty narrow window of visiting hours where people can come.
Mm.
Yeah, and I saw actually, which is really nice. I don't know if you have any programs like this, but we have the caring canines, you know, the support dogs, and I just saw the support dog, or at least one of them, you know, several days ago, and I thought, oh, that's good. At least they're back. 'Cause that's, people love that.
Yeah.
Yeah, we have I forget what they call it. The dogs come into the hospital with their handlers, the volunteers, and they go visit. I don't think they've never been allowed down in the chemo suite, perhaps the radiation oncology waiting area. I don't know. Joan, have you ever seen any dogs in the waiting area?
You know, I had such a funny experience. One of the patients that I had seen and had a relationship with had come in one day and said, I knew that she was looking for a dog. And I said, how has your search been? She said, oh, we have a dog now. I said, oh, what kind? And where is the dog now? The dog's in the car. I said, go get the dog. I've got to see the dog. And at that point, the, I forgot his name, head of the Department of Oncology.
Oh, John Powell?
Yeah. He walked by and he saw the dog. He said, is that a support dog? I said, oh, yes. He looked at me kind of strangely and went on his way, but I know the difference that an animal can make in your life. And I just could not let this woman get out of there without bringing her dog.
Yeah,
Very nice.
that was quick thinking, Joan.
Mhm. Good deal.
So, Anne, I just have, when you were talking about all these different methods for shrinking or freezing or heating up the tumor, I just, in my head, I picture like you have all these different instruments in your office and you kind of just grab one. But I mean, we're just so used to this humongous delivery system of radiation. You know, when patients go into our RadMed or RadOnc, they have to go in this room with this, you know, humongous thing. But it sounds like you have like, you know, different machinery that you can use. And I'm just wondering, like, it sounds like a lot of them are very small in terms of, I mean, the catheters obviously go in small, but then the things that you attach to them to do the freezing or whatever, it doesn't sound like super high tech or anything, but maybe you could just talk a little bit about some of
Sure.
them.
It's crazy super high tech. And yeah, my procedure room, because we do it in the, you know, an operating room, would make your radiation oncology room seem pretty bland. There's a ton
really?
going on in our room. So, you know, most of our rooms have, you know, CAT scanner because we use imaging for guidance. So we have a CAT scan in the room. We also have sort of that live fluoroscopy. So most of the time I'm doing something with my hands and looking up at a screen with a camera right over the patient, sort of showing me live x-ray. So we have that in most rooms. Most of our rooms have a big ultrasound machine. And then we have the other machines to help us do the things that we need to. So for example, you know, that you're right, the machine that cooks things, you know, the current, it's, you know, it's like a microwave. So it's like, you know, it's that big. But in order to do anything, you know, I have like a $1.5 million piece of equipment that costs like $1 million to install in this room. And I can't do anything without any of it. So, you know, it's not generally applicable to, you know, one of the things, you know, after medical school, I went to Thailand and worked in a refugee camp for 3 months, which was awesome. But I can't do much of what I do there because I need a giant, fancy, crazy high-tech room to do it.
Wow. That's interesting. That's kind of I didn't think about all the like the supporting equipment that you would need to actually do the delivery of the therapy. So that's really interesting.
Yeah, and for every procedure I have, you know, a nurse anesthetist because we do most of our procedures under general anesthesia. I have 1 or 2 technologists helping me run the room and just run the equipment in the room. And then a nurse typically monitoring the patient.
I have a question. just wondering if they're looking at the ways of delivering radiation that might reduce chances of lymphedema.
Yeah, so lymphedema is a problem for breast cancer patients, who get radiation to the axilla. I mean, fortunately, it should be a pretty rare complication. No? Oh, yeah, all right, fair enough. Well, it should be, a pretty uncommon procedure. I don't really have a lot to offer in that area. And I think they've gotten better with their radiation, with targeting, and can really, better define, targets, but, it does happen sometimes.
I'm
I don't
just,
know if we made a whole lot of improvement there.
I'm just wondering why some get lymphedema and some don't. In 1986, I had radiation therapy. I never had lymphedema.
Yeah.
So you're talking about targeting
Yeah.
as a way of treating or avoiding the lymphedema.
Well, most people don't get lymphedema anyway, but obviously when somebody does get it, it's, it's life altering. But that's a little out of my area. I mean, that's sort of in the radiation, the oncologists, the radiotherapists area. But, fortunately uncommon and should be getting less common, but, not zero.
Okay.
These lymph channels are so hard. Occasionally I treat actually people who have lymphatic leaks in the chest sometimes or in the abdomen. And, blood vessels are really easy. It's pretty easy to stick a needle in almost any blood vessel, if you can see it with ultrasound. But these lymphatic channels, they're like spider webs, and they're really hard to see and to get into and to avoid. Yeah.
Is some of it the, like for instance, when they have breast surgery, does it matter? I mean, I'm not involved with that, but I know some people here are for sure. Is it the kind of surgery they have, if they can avoid some of the lymph nodes and so on, there's a better chance? Or
Yeah, so one of the things that they do, and again, I'm not really a breast person, so this is, maybe not the most nuanced discussion, but on my part. But one of the things that they do now is sentinel node mapping. So, when somebody has a breast cancer, they'll either inject a little radioactive material or sometimes a little methylene blue dye, so that when the surgeon goes in, they can see which node is sort of the first one to drain from the area of cancer. And the idea being, if you then take out that node and that node does not have cancer, then it's less likely that, other nodes downstream would have the cancer. And the idea being that if you just, can take out that one node and not sort of take out a whole lymphatic chain, that you would cause people less, detrimental effect like lymphedema.
Mm-hmm.
If you go in and take out that lymph node and it's positive, well, then you're going to keep, keep going. And the more nodes you take out, the more nodes, the more likely it is that somebody's going to have problems and not develop collateral pathways.
Mm-hmm.
If you think about that sort of main channel, like, I don't know, what's that root up there, 81? And you take out, a bunch of nodes and you're left with, other channels. Eventually, you're going to have traffic build up because there's nowhere to go.
Yeah. Thank you.
Any other questions, comments?
Did we lose Sharon, or is she still there?
No, I rejoined on my laptop. I can't stand
We're
sitting on
bouncing
my,
around.
I know, sorry for the, yeah. It just, Murphy's Law.
Yeah,
One storm that hit, when was the last time we had a storm here? Like August? And then,
yeah, this great speaker from Sloan Kettering, and
I
then
know.
comes the storm.
And my husband, the calls before, the constant ringing was him trying to warn me of this
Oh,
storm coming. I'm just like, well, I'm not going anywhere.
oh,
So, yeah, anyway, so apologize for a little stutter step, but, and thank you so much, so much. This was
Thank
really
you.
interesting. And
Wonderful,
yes,
really.
it's something that we haven't really, I mean, we have Dr. Powell come and speak with us every now and then, but what you're doing is so different from a lot of the procedures that can happen at our local cancer center. So it's just fascinating for us to learn about them, because our our clients or patients do get these procedures, but we don't.
There
They're
is,
not.
there is an interventional radiology guy I know practicing at your center. What's his name? Roman Politi.
Dr. Politi, yep.
Yep. So, I know him. He was actually in Indiana when I was there for a year.
oh.
He was like a really good guy. So there are, you might not be aware, and most patients aren't even aware, but, we're out there even in your neck of the woods doing these things.
Yeah. Well, I'll have to ask him if he does. I don't know, Bob, do you know if he's done any work on any of our clients or any?
He does. I know that he places lots of ports.
Mhm.
And
And
he also did
ablation, yeah.
where he did chemo directly into tumors at the liver with the client just last week. So
No kidding.
Oh, right. Yep. One of our
Yeah.
clients.
Well, that's the embolization.
Yeah.
We do it with just the particles, but you can do it by putting chemo in there. So absolutely, that's exactly what we were just talking about.
Mhm.
And do you know of any, I mean, they must have at Sloan some sort of volunteer program where volunteers are there visiting with the patients, helping out in any way. Are you aware of any volunteers who?
Yeah, so we have two sort of main programs that I know about. One is the Caring Canines, which, I mean, they actually have a bunch of dogs who come in, and go to all sorts of floors. We actually there are a lot of groups I know about now that I think about it. There's the Big Apple Circus comes in. We have clowns from the Big Apple Circus come in, and they sort of just roam the halls for adults and children. They're very clever. They're very funny. They're good distractions. We have some music volunteers come in and will just sit and play guitar for patients, which I think is pretty well received. And then finally, the group that I mentioned, which is that Patient Family Advisory Council, which is really very active. And that is, it sounds like some of you, patients who have been patients and experienced, treatment at our center, then giving back and sharing, that with other patients. And they are incredibly active. I mean, this group is, I'm the chair of that group, and I joined just a year ago. And I have to admit, I thought it would be, getting together a few times, maybe every month or so, hearing about what they're doing, but they're constantly calling about, making sure that Memorial is sharing their COVID response with all the patients, making sure that patients aren't, getting lost in COVID, making sure that we do a better job of accessing patients who have, with a more diverse patient population. So they are just phenomenally active. And and we have actually, a lot of high school volunteers who help transport patients with the transporters. We have, there's somebody, I don't know, years ago, before I even got there, donated some insane amount of money to make sure that orchids, I don't know if any of you have been to Sloan Kettering, but if you have, you've seen orchids like all over the place in patient rooms and the common areas and whatever. And, somebody left an enormous amount of money to make sure that that would continue on in perpetuity. So we have the orchid volunteers, like delivering orchids all over the place.
Amazing. Wow.
Lots and lots of volunteers, but each one of them I think has a crazy, important role in helping us take care of people. I think, as I was saying, I think Sharon, when you were off, is that, medicine has gotten to be so much more, the providers, nurses have less time to spend with patients, doctors have less time. We're all spending times with our, computers and health systems. So I think it makes the roles of volunteers all the more important because the volunteers have the time, and time is everything.
Mm-hmm.
And who determines or what determines the kind of treatment? For instance, my brother with the lung cancer had surgery. He also had kidney cancer, and he had, I think, the cryosurgery for that.
Cryoablation, and that's what we do.
Yeah, but what who determines that? A surgeon or you or an oncologist or a combination thereof?
Yeah, so it should be, and this is a philosophical sort of answer, and I think that one of the benefits of coming to a place like Sloan Kettering is if you come in with, say, a 3-centimeter renal cell carcinoma, whether you come to see me first or surgery first or an oncologist first, you sort of get funneled to, into an algorithm as to how we think those patients are best treated.
Uh-huh.
I have to say I've worked other places a little bit, and sometimes, it is. If you go see a surgeon, you're going to have surgery. If you go see an interventional radiologist, you're likely to have a cryoablation. If you go see a medical oncologist, well, maybe you're more likely to have chemo. So when patients, ask me if or why they should come to Sloan Kettering, or why I think it's a great place, and I do, a lot of it is because I think we have a very team-based approach. And not to get too cynical about it, but we follow what's called a clinic model, meaning we're all employees of the hospital. So there's no financial incentive for me to do something, that I think would be better done by someone else. And I think taking that out of the equation allows us to do what we think is the right thing. That said, I think if you can tolerate surgery for lung cancer, surgery's the best. As far as kidney cancer goes, I think there's good data suggesting that, depending on the size and location of the lesion, that outcomes, meaning survival, is pretty equivalent between surgery and cryoablation. So I'm not saying the wrong thing in any which way was done. It sounds like it makes perfect sense. And I don't know how quite I got off on that.
Thank you.
Answer.
That's great.
I short-circuited.
Well, no, I think we do hear that from some of our clients who are a little concerned that, the first person they saw was a surgeon, and then they're like you were saying, they recommend surgery. So I think the team approach is advantageous for the patient, because it's doing what's best for the patient, not just, the specialty of whoever they're going to see first.
Yeah. And it's hard, right? I mean, everybody's incentivized in some way, and it's we should all be incentivized to do the right thing.
Yeah.
Amen.
Amen.
Okay. Well, if there aren't any final questions for our fabulous guest here, we can we'll wrap up. But thank you again. And
Many thanks.
coming.
Thank you, Anne.
Round of applause.
Yeah, it's been really helpful. Thank you.
Super fun. Well, thank you guys for doing what you do. It's really, it makes a huge difference for patients. I have no doubt about it.
Yeah. We're hoping to get back sooner than later.
I know.
Oh, boy.
We just keep saying that and then hoping for the best. So,
All right. Well, thank you. Stay safe, everybody.
yeah,
Thank you.
Okay,
You
thank
as
you
well.
very much.
Thanks, Dan.
You as well.
okay. Goodbye, everyone.
Bye.
Bye.
Okay,
Goodbye. Stay out of
Bye-bye.
trouble.
You too.
Okay.
Never do that.
Wow, that was amazing. Oh,
Good.
but
You know,
brings me back to what I miss most,
You know what, Sharon?
getting into the hospital and spending time and
Yeah.
finding out how to be a better listener, and sometimes sitting in silence is exactly what the patient needs.
Mhm.
Yeah.
Wow. Someday.
Someday. It was interesting to hear her mention the Patient Family Advisory Council, because I
Yeah.
was on that at Moffitt. So I know how active they are. So that was kind of cool to hear. I mean, all the other stuff was awesome too. So
Yes, it was.
It's an amazing
Was.
place for sure.
Mm.
thank you, Sharon, for
Yes,
thinking
thank
outside
you.
of the box, or thinking outside of the Ithaca box.
Right.
Right. I know. I know. It's like, wow, who else can we get?
Wow.
We'll have to.
You
put our
got
heads
connections,
together.
girl. Yeah.
Yeah.
Well, thank you, Sharon.
It
You're
was
very
great to
welcome.
see everybody.
Yes.
Yep.
Right.
When do you
Everybody
leave
be
again,
well.
Oh, I
Take
see
well.
the dog. Okay,
What
bye-bye,
was that,
guys.
Nancy?
I wonder I forgot when you leave again.
Monday.
Oh, wow.
Yeah.
Okay, I knew it was soon, but I didn't know it was quite that soon. Okay.
Where are you leaving for?
Atlanta, Georgia.
Ooh.
Oh.
My son's getting married.
Oh.
So
Wow. Amazing.
amazing. Feels like it's been forever. We've been planning this, and then you add the whole COVID thing. So, but we're going to do it. So looks a little different than a normal wedding, but
That's okay. It won't be snowing there. It's all right.
Oh, and lots of pictures.
it's going to be 70 and sunny every day.
Nice.
So I will take it.
All right. Have a wonderful,
Wow.
wonderful time.
I will. So everybody have a great evening.
Okay.
Thank
too.
you. Thank
Okay.
you. Thank you.
Bye-bye.
Bye-bye.
Bye.
Bye. Bye, everybody. Been great. Okay, puppy, I'm gonna take care of you, all right? You're my good girl. Huh? Okay. All right, puppy. You want to eat?